My name's Jo Harvey and I work as part of Helen Sanderson Associates, and for the last 9 years I've been working around the personalisation agenda, starting firstly in social care, and then really for the last 4 years I've worked on the personal health budget pilot work with the West Midlands Strategic Health Authority and then many of the personal health budget pilot sites. Our particular focus has been on support planning. Before I really get into the webinar, I'm going to hand you over to Kerry, and Kerry's going to give you some housekeeping tips for the rest of the webinar.
Thank you, Jo. Hello everybody. Just so that I can check that you can hear myself and Jo okay, on your screen in front of you there will be an icon of a hand. It might be a grey hand or it might be a yellow hand. Please could you click on that hand, which will then show me that you can hear me. That's excellent, thank you. If you could please click on the hand again to take it away. Wonderful, that's great, thank you very much. What's going to happen in a few minutes, obviously Jo will begin today's webinar, and during the webinar at any stage you can type into the questions box that you'll be able to see again on your screen in front of you. If you have any questions or any comments, you can type them into that screen, press enter, and what it will do is send the questions through to myself and Jo. At the end of the webinar, what I'll do then is I will read the questions out to Jo. Jo will answer them one at a time, and then what we'll do is obviously any comments that you have, we'll also read those out for Jo as well. And that's all of the housekeeping, so I'll pass it back to Jo. Thank you, Jo.
Thank you, Kerry. So, just thinking about what I wanted to talk to you about today in terms of the personal health budget work. I'm not sure how many of you know, but the evaluation into the personal health budget pilot that was run by the Department of Health was published on it was 2 weeks ago, tomorrow it will be, on the 30th of November. Much anticipated by a number of us. And when we were planning this webinar, I thought it would be useful to find out what that evaluation had said around support planning. So really one of the things I want to talk about today is just the key findings. What was quite interesting was that in the evaluation report there wasn't a lot about support planning. That's actually come from the toolkit, which I'll make reference to a bit later on. So what I'm going to start by doing is just exploring the key findings from the pilot evaluation, just to set the context for that. Then I will share what we've learned so far about support planning in health with a personal health budget. And then I thought it would be really useful to talk to you about person-centred health outcomes, as that's one of the biggest issues I find that practitioners are struggling with in relation to writing really good support plans. And we've been doing a lot of thinking, a lot of new thinking over literally the last few weeks around outcomes. And so I felt it would be really useful to be able to share our most up-to-date thinking around that. So hopefully that's okay for everybody. So thinking about the personal health budget evaluation report. So the pilot really aimed to improve patient outcomes, and it really fits with the much broader personalisation agenda that we have had in this country over the last few years, well certainly since 2007 and the publication of Putting People First. And really what the pilot wanted to do was to test that if by giving people much greater choice and control over the support that they receive, over their decision making, about how they want to receive that support in ways that make more sense to them, whether that would encourage much more responsiveness as part of the health and social care system. There was about 20 pilot sites that were involved in the research, and therefore it's the results of the work of those 20 pilot sites that are part of the evaluation report. But actually there's been a wider cohort of about 64, I think, and probably more now, but about 64 pilot sites that started the work back in 2009. So quite a lot of information that's been collected over the last few years, really. So just to talk to you about some of the most significant key findings that the pilot has shown us, really. I think one of the most exciting things for me was that there had been a significant improvement in people's quality of life and their psychological well-being. And also, really importantly, their health status stayed the same. So there was a great deal of fear, really, that by people having more choice and control over their health, that actually that would affect their health and their health would deteriorate. And in fact, the evidence and the from the evaluation report that that hasn't happened. The health status stayed the same, but their quality of life and psychological well-being was significant improvements, which is key to understand. I think that comes because we are looking and working with people in a much more holistic way, and that's really part of the planning process, that we've started to see people as people and whole people, and look at help them look at their lives within their whole social context, not just people defined by a health condition. So that was a really key finding. It also said there were the benefits of a personal health budget were much more marked where people had higher levels of needs. And I think that was probably because about how some of the pilots constructed their work. Where pilots were working with people who have continuing healthcare funding, what they were able to determine was that they could use real budgets, the real money that people would have used if they were receiving support through a more conventional way. So that was quite interesting. Other pilot sites, working maybe with people with long-term conditions, chose to just give people a small amount of money, maybe a sum like £500, where they were able to just test out what sort of differences that would make and how people might use the money differently if they had control. So I think you saw less benefit because we had less money to work with in that way, and maybe it wasn't the real budget as well. And also, very interestingly, another key finding was where pilot sites actually gave people as much control as they possibly could, where they didn't impose a lot of restrictions, it tended to have a much better outcome, and people felt it was much improved. So that was fantastic. And there were some great sites that I worked with over the last 3 or 4 years where that was really possible. Sites like Oxfordshire and Manchester and Mean Commissioning, they're just some of the ones that I worked with that had tried to give people as much scope as possible to choose how they wanted to be supported. So they were some very interesting key findings. Some of the others, people reported really positive impacts for themselves and for family members. But I guess one of the key things was this change in relationship that people had with their healthcare professional. One of the things that we talk about in planning when we're talking about planning within health is that we want people or patients to be active participants in their care planning process or their support planning process rather than a passive recipient. And I think what the evaluation report has shown is that we've seen that kind of change in the relationship where people are seen as equal partners making equal decisions together, which has been really fantastic. And also I think for carers, as part of any of the planning that I have been involved in for people with a personal health budget, what we're trying to look, when you're looking at somebody's whole life, you're also looking at how this works for people who have a caring role in that person's life. And therefore I can see why there's been a perceived sort of increase in the quality of life and health of carers than those that were in the control group, really. So that's been very interesting. Also, I think probably one of the things that many people will be very interested in, particularly financial directors, I would think, of CCGs going forward, is that actually the evaluation found personal health budgets to be cost effective, particularly for people with continuing healthcare and for those who use mental health services, which was great, really great. And I think there's a number of reasons why that has happened. One of the ones that's suggested here is that people are choosing to meet their health needs in different ways that maybe cost less. So, for example, being able to train their personal assistants or their carers to carry out health tasks that might previously have been carried out by a qualified nurse. And there's some real challenges with that, and particularly challenges when you're planning and you're developing a plan about how we can monitor and ensure the competency of the people carrying out those delegated healthcare tasks. But it is possible to do, and that's a key part of the planning process that we have been looking about. How can you record that? How can we be comfortable and sure that the people carrying out those tasks are competent to do that, and how can we review that they maintain that competency, and that's a key part of the planning. But that means it can be a lot more cost effective as well, which has been really interesting. I think some of the other ways that people have found to be more cost effective is that they aren't necessarily buying things that traditionally the NHS would offer. So they've looked at doing things in a different way. And that can and will have an effect and an impact on the market as we go forward, really. And I think one of the key things as we see a wider rollout of this, certainly in continuing healthcare, is that commissioners need to look at how they can collect information from people about the kind of things that they want to purchase with a personal health budget, the kind of services they want, the services they don't want, and also what gaps there may be in the market that strategic commissioners need to develop further. One of the things that we've learned from the implementation of personal budgets in social care is that this is really, really key to inform that strategic commissioning. And we use a process called Working Together for Change that you might be interested in finding out some more about, which can really help strategic commissioning. And that's learning directly from people's plans and the reviews of those plans to find out where the gaps are, really. And also, I think when we've had these, where people are finding much more responsive and cost-effective ways for their support to be delivered to them, what we're finding is that they are much more compliant. That's a word that's used a lot in health, or you hear a lot about people being non-compliant. I always think that people who are non-compliant is just that we haven't got it right yet. We haven't understood what the right solution for them is. And so actually where we do get it right, then that means that people are happy and things don't break down, packages don't break down, and therefore there aren't costs associated with that as well. So I think that's probably another reason. And then lastly, on this last point on this slide, is that the inpatient costs of people fell, so less people were staying in hospital, which is really, really interesting. And again, I think that's a reflection of we're finding the right solutions for people because we're working really well with them at the planning stage, doing that in a very person-centered way, and therefore we get the solution right at the beginning and we don't have to change that again. So those are some of the key findings that the evaluation report has shown. And you can pick most of those up by just reading the executive summary. The report itself is 220 pages long, so it's quite hard going. So I would recommend looking at the executive summary as a way forward if you're going to have a look, if you haven't already. Some people might have. I've not quite made it all through all the 221 pages yet. What I also wanted to mention was some of the recommendations that the evaluation report has now suggested that as a way forward, really. So it's still talking about a rollout. The pilot has always talked about a rollout. It's always said that this was to see how it might work, not if it works. So it was always a suggestion that it would be carried forward. And really, because of the cost-effective nature that they've evaluated, therefore, I think it supports a wider rollout. One of the key things it's suggesting is that initially a wider rollout should be targeted at people who have a greater level of need, because that's where the evaluation has seen the most impact, and there is it's an ideal place to start, really. So I think we will see that. We have already had an announcement about continuing healthcare, which was an announcement made in October 2011 that anybody who will be is in receipt of continuing healthcare, NHS-funded continuing healthcare, from April 2014 has the right to ask for a personal health budget. So we've seen that, we know that's happening, and we know continuing healthcare teams are now actively preparing for that. But I wonder if we might see some more wider announcements that may come out. Because it's also been found to be very effective in mental health, I would think there may be some announcements made around mental health, but I'm not sure how soon they will come. I think it has felt easier to look at it and look at a wider rollout in continuing healthcare, because there's a very clearly defined pot of money. Each continuing healthcare team has a budget, and the role with personal health budget is to break that up into individual bits of the budget in relation to the level of need that somebody has. In mental health services, you have a much more difficult task at the sort of disaggregation, really, of the money, and that's a real issue. So I think there may be some time before we see some announcements there, but that's a possibility, really. So looking at some of the other recommendations, as I said, the findings showed cost effectiveness in continuing healthcare mental health. But in the other areas where it was tested, like working with people with long-term conditions like COPD, diabetes, chronic heart failure, the sample sizes for those pilot sites were too small for any really conclusive information. So I wonder if we need to test that a bit further, really. And as I said earlier, some of the pilot sites maybe gave people an amount like £500, which wasn't related particularly to their level of need. It was a pot of money to see how they might use it differently. And I guess it's actually around looking at that in a much wider way to get further information. One of the key things that people, budget holders, said was they really valued the information and guidance on the size of their budget and being told that up front. So the model of self-directed support and personal budgets that's been implemented in social care has a really clear part to that process, that you give people an indicative budget up front. So before you begin planning with them, based on the level of need that they have, they're given an idea of the money that will be available for them to spend. And that's a very different way to begin planning, because if you don't know what budget you have, it's much more difficult to plan for. And I liken it to booking a holiday. And if we were booking a holiday and I had no budget, I'm going to the Maldives, for example. And then if somebody said, well, you've only got £400, then it's maybe a caravan in Cornwall, if you can even get a caravan in Cornwall these days for £400. So knowing how much money you have can help you be a bit more creative. Because then I might say, well, I've got a friend who's got a villa in Spain, and they've always said I could use it for free. So I could I've only got to pay for my flight. So it begins to help you to think more creatively. And what the evaluation report has done is backed up just how important that was to people. So knowing upfront what money they had and what that money could be spent on, so whatever restrictions were placed. And the key bit to know is that the Department of Health has placed very little restrictions on what you can use a personal health budget for. Where the restrictions came in was from the pilot sites themselves. And actually what as I said, as one of the key findings, is the more restrictive people were, the less successful the pilots were, really. So that's been really great. And then one of the other recommendations is that we need to understand further the scale of change that may come about as people begin to use non-traditional NHS provision to meet their healthcare needs. And as I spoke about briefly before, there's some good ways that we can do that, but we need to understand that because that will change the market. Alongside the publication of the evaluation report has been the Personal Health Budget Toolkit. And this is where we can start to get some really clear learning from the pilot sites about support planning, which is more about what I want to talk to you about. So this has got a real wealth of information, and you can find this on the Personal Health Budget website, which I should just give you the address now, is www.personalhealthbudgets, so that's personal health budgets, all lowercase, all one word, .dh, lowercase that is as well, .gov.uk, so .dh.gov.uk. And if you go onto that website, you can look for the Personal Health Budget Toolkit. You'll find that the toolkit has 4 sections, and under each of those sections there's a range of different papers, best practice guidance, just really good examples of information that the pilots have worked on over the last few years. In the introduction, there's a lot of information that you can use to introduce people and patients to the concept of personal health budgets. How to get good results, that's the key learning from the evaluation, and is set against some of the key findings that I've already explored with you. How Personal Health Budgets Work has got some really practical guides, particularly around budget setting, care planning, managing budgets. And the Making Personal Health Budgets Happen section has got information around kind of workforce development, working with families, integration, more information about the finance side of it as well. So they're really, really useful set of papers, and there's more to come. Myself and some colleagues have been working on a paper around advice, advocacy and brokerage, for example, but we'll go on to that toolkit as that is finished and developed. So what I want to really focus on is a toolkit that's in the How Personal Health Budgets Work section, a paper, sorry, that's in the How Personal Health Budgets Work section of the toolkit, and that's called Implementing Effective Care Planning. So we're still using the term care planning here. When we're talking about that, we are talking about support planning, and there's a real mix-up of words here, so I just want to share that with you. So where it does say care planning, we are still talking about support planning. Support planning is the term that is used in social care, and many of the pilot sites are using that term to describe the plan that somebody has to write in order to show how their personal health budget will be spent to meet their health needs and their health outcomes. So, but care planning is a really key word in health. So DH is still using the term care planning, and hence why this document is called Effective Care Planning, but we are talking about the same document. So this is a good practice guide that's been developed, was written by a lady called Rita Brewis, who used to work for In Control and led the In Control health work. And a number of these slides that I'm going to show you now are her slides that I've got permission to share. And Rita worked with the Personal Health Budget User Network, peer network, which is kind of what it says really. It's a peer network that's been developed of personal health budget users. And the guide is just really about what are the things that we know have to be in place for effective care planning to take place. So it talks about what a personal health budget is and how it's about a culture shift and working with people in a different way. And it talks about a framework, and this is the bit that's, I guess, really important to know, is that it's having a framework sets the context for which the planning will happen, and having a framework that's not too restrictive, what the evaluation has shown enables people to be much more effective with the use of their personal health budgets really. So the framework is kind of what we call the deal really. And why does it matter that we have the framework? I guess it's about people having that chance to move really from a world where other people know what's best for them to actually understanding that they are the expert on what their health condition or the impact of their health condition on their lives, okay? And that can't be isolated. They bring that expertise, whereas health practitioners maybe bring expertise around the health condition and the treatment and support options that may be available. And that's why really getting this right I think helps people to do that, and the planning is the way to make that happen, and that's one of the things that we think is really important. So the deal, Rita always calls this the deal, and it's just a nice way of saying that you really need to have this framework in place if we're going to make this work successfully really. And the idea of the framework is for people to understand, both the person themselves and the health professional that may be working with them on the front line, they both need to know what is expected of them in order that you can create a really good care plan, and then that care plan can be authorised and very successfully put into action. And if everybody knows what's expected in that plan, then that means that can happen. So it kind of informs and shapes the individual conversation that you may have with the health practitioner and helps you share that decision making. And as I said, what the evaluation has shown is if that is too restrictive, it means that the personal health budgets have not been so effective. I've worked quite extensively with Oxfordshire, and the personal health budget pilot lead in Oxfordshire is a lady called Trudy Reynolds, and we've written a paper together that talked about what were the what's her key learning, her key insights into implementing this they've implemented initially in continuing healthcare. And one of the things that Trudy says, if you've got a good framework in place, if you've worked out the rules and you've worked out the deal and you're comfortable with those, and you know that you've got your governance in place, then as a commissioner you can let go. You can absolutely let go, and you can trust that people will do the right thing for themselves. And that's the really key thing. So that's why a framework like this is really, really important. So it's not just about a piece of paper. A planning sort of process is not about having a really nice document or a really nice template. It's about having an active relationship with people, which is a real change in the culture, very much of the NHS, really. It's that active participation and rather than the passive recipients of a planning process, really. And it's really interesting that one of the key findings from the evaluation has shown that there has been this significant change in a relationship between NHS practitioners and the people that they are working with, which is really, really good to be able to hear. So, developing a plan. The care planning has really shown that it's the heart of the whole personal health budget process. There's a lot of technical stuff to do around making sure you can give people the money and the governance and all of those things, but actually if you don't get care planning right, the process won't work very well at all. So good care planning is that we see whole people in their whole life context. And I remember when I was training some continuing healthcare staff about a year ago, I remember a practitioner almost stamping her foot and saying, but I've been told I can only spend money on health things, and now you're telling me I have to look at all these other bits. And that's not actually what we're saying. We're not saying you have to spend health money on things that maybe fall under the realms of social care or are about a wider context, but you need to understand them so that you can understand the impact on somebody's life when we suggest this type of support or this type of solution. Because sometimes people will not engage with services because what we offer them impacts too greatly on something that's really important to them. And that's one of the key things that we really need to see in the plan, that we understand those impacts as well. Okay, so what the paper says, the Implementing Effective Care Planning paper says, is there are 5 key things that we need to have in place in order for a personal health budget to be successful. People need to know how much money they have, okay? So they can use that information to plan and budget with, which is what we spoke about earlier. They need to choose the outcomes, their personal health outcomes to be achieved, and agree those with health professionals. One of my biggest light bulb moments was about 18 months ago when I was mentoring a care navigator as part of the Oxfordshire pilot, and she was responsible for the planning. She was new into post and she wasn't a healthcare assessor but had come from a continuing healthcare background. And she said what she discovered was that health practitioners would complete the assessment process, which in continuing healthcare is a decision support tool, and probably additional nursing assessments. And then they would pick up the phone to a provider and say, this is what people need, these are the hours of support that people need. And what was missed out was the step around working with the person to say, what do you want to achieve in relation to this particular health need that you have? And that's been one of the most significant changes that we've seen in the care planning or support planning work that I've certainly been involved in, is that we're starting to work with people to think about outcomes, which is why I'm going to mention those today. So that's really, really significant. So that people are able to create their own care plan. So there's not an assumption that people can't do this themselves. We start with the assumption that they will do that and they will get whatever help they need to actually write their own support or care plan, so they write it well enough to meet the criteria. The person gets to choose which way their budget is held and managed. There's 3 ways that you can hold a budget, a personal health budget. It can be held by the funder, which is currently a PCT but will be a clinical commissioning group, and that's called a notional budget. The person chooses how it's spent, but the money, the commissioning is done by the fund holder. You can have a third-party budget where the money is passed to a third-party organisation, maybe a user-led organisation, maybe an independent user trust, possibly a voluntary sector organisation or a private sector organisation, and they hold the money and they commission the services that you want. So again, the person has choice. Or they can have that, they can manage that as a direct payment. So running alongside the evaluation work and the pilot was a pilot for direct healthcare payments, because they weren't legislatively possible until June 2010 and the healthcare bill of June 2010. They've only been possible under that pilot, so you had to apply for a pilot. I think about well over 60 PCTs applied for direct payment pilot status. There were many that were outside of the core evaluation sites, and that window of opportunity is held at the moment. That's stopped at about June, and whilst they write the regulations for that to be fully implemented, which should come out next summer, nobody else can get pilot status until that point. But there's plenty of examples of where people have been managing their budgets as a direct payment. And then the last one is, whatever option somebody chooses to hold and manage that, they are able to spend it as flexibly as possible to meet their actual planned outcomes. So they're the 5 key things. Why do we need these rules? Well, I think in a way I've already said some of this. If we are shifting power and control over to people, they need to know what's expected of them, and to expect people to manage a budget without knowing what is expected of them means it just wouldn't work. So that's why it's important. And I think a lot of people think choice and control in this agenda is about, well, you can anything goes, and you can go off, and people are going to run away, and they're going to spend their money on a cruise to the Caribbean. It's not about that, and it's not possible to do that. So the rules are there to guide both the individual that is making decisions about their healthcare, but also the professional that has to authorise that plan as well. So what we're looking for is real balance in plans, and the rules help you to get that balance. So money isn't going to work alone. People need good information. They need transparent processes. They need to know what that deal is that we've talked about. And there really, really needs to be a shift in thinking. And it's a shift in thinking really from not only health practitioners, that cultural shift that we need to see, but I think it's a shift often in people's mind, in expectations of patients who sometimes don't have very high expectations at all. So I think that is also something where we need to see some real changes in people's thinking and behaviour as well. So from patients, not just from practitioners. What the paper does say really clearly is this is the recommended criteria for authorising a care plan, which therefore means it's the recommended criteria for what should be in a support plan. So for anybody who is supporting somebody to complete their support plan or care plan, these are the things that people will look for. And a little bit later on, I'm going to show you my latest thinking on how I put together a plan and develop that. So it must show who the person is, with their strengths and skills, their social context as well as their health needs. It must show if around decision making, particularly where people lack capacity around decision making, and who may be speaking on their behalf. It should describe what is working and not working from their perspective, and I think actually usefully that can be from lots of different perspectives, and I certainly use that information in that way. It must detail what is important to the person and what is important for them in relation to their health. It needs to identify and address any risks, how they will be mitigated to an acceptable level, and how we plan for contingencies if things go wrong. And that's really, really important. So the bit that decision makers are really focused on is around risk and contingency, and we know that, and therefore a good plan must show that. The plan needs to state the health outcomes that are going to be achieved, and I've got some ways of showing you how to do that. It needs to show how the money will be held, so whether it's a direct payment, whether it's a third party or a notional budget, and it needs to show how it's going to be used to achieve the outcome. So it would include things like a budget sheet. It needs to have an action plan, needs to name the name of the person who is the care coordinator, so the lead person. And then it needs to show how and when the outcomes and the money will be monitored and reviewed. For some people, there may be some elements of their plan that need more rigorous reviewing because you're trying out very untraditional things that we don't know whether they're going to work, and therefore take a greater level of monitoring, really. So that may be something. We would see different levels of monitoring within a plan. So they're the main things that we'll be looking for. So just thinking about the issues, really, and these for me are the challenges that I've seen over the last few years in actually trying to do really, really good support or care planning. One of the ways that we need to really change that culture, that cultural shift that both the evaluation report has referenced and the effective care planning document has also mentioned, is that we need to change the nature of the conversation that happens between people and healthcare practitioners so that it is much more holistic, that it is much more person-centered. Another key piece of learning is we can't make it too complicated and too lengthy if we want people to take as much control as they can and they want to. And that's some of the next slide I'm going to show you is some of the thinking I've done to try and really help loosen that much more and make that much more simple to be able to do. We need a framework for planning, as I've spoken about before. A blank sheet is great in terms of creativity, but it's usually not enough. It's not enough for me, and I've done a lot of planning, so understanding what you can and can't do is really important. If I'm really honest, the decision maker at the bottom line really only wants to see information on outcomes, where this adds value, what the costs are, what the risks are, and what the contingencies are. They aren't as interested in the things that are really important to people. That, I think, is really important to have in, but that's not what they're necessarily looking for. So a way of showing that really quite easily can be really helpful. Most people find it really hard to actually understand what a person-centered outcome is, and that's a real challenge, and that's something I want to do with you in just a minute. And we need to link our outcomes much more clearly to our assessed eligible needs, so people, decision makers, can see that link. They can see how it meets people's needs. So this is a little strange drawing, and this was literally about trying to get some ideas down onto from my head, actually. So on the left-hand side, it says tools for the conversation, and these are the tools that I use, and for much of the training that I do around support planning in health, these are the tools that I would use. So these, if you had any experience around person-centered thinking tools, these are the tools that you will recognize. Relationship maps, decision making, good day, bad day, are important to and are important for keeping us healthy and safe. Working, not working, helps and hinders, perfect week. So they are the tools that shape the conversation. So having just said on the previous slide, we need to change that conversation. These are some of the ways that you can do that. They give a framework for a practitioner to have that conversation. In the middle column, these are what I think could be the support plan at its simplest. You could start with a one-page profile. A one-page profile is just a simple page of person-centered information. It has 3 sections. This is what we like and admire about somebody. This is what is important to them. This is how best to support them. The last support plan I wrote for somebody with a personal health budget, I spent 6 pages doing that. And then I suddenly thought, I can make this so much more simple if I just did that as a one-page profile. So that's what I've been testing out most recently. And then the other things are really what have come from the effective care planning paper. So it has a working, not working in it. It has an outcome grid, and I'll show you what I mean by that in a minute. It's got a page that looks at risk and contingency. It's got a budget sheet, which also says how the budget's managed. It's got decision making and review, and it has an action plan. And on the right-hand side, there's an idea that's being tested out in social care that actually we could develop a one-page summary for decision makers. It's not been tested in health yet. This is just some thinking I'm doing with colleagues in my organisation about whether that's possible in health. So what the decision maker might see is a one-page summary, perhaps based around that criteria for authorising the care plan. And if they need to see more to be able to sign a plan off, then they look at the pages in the middle column And if they needed to see even more, they might look at some of the information that's gathered through using person-centered thinking tools. So that's just some up-to-date thinking about support planning, really. So the last thing I want to talk to you about is outcomes, and just really my freshest thinking about outcomes. I'm going to whiz through a few slides here. I think we're great at measuring activities, we're great at measuring processes, we've got lots of ways of doing that, CQC, Ofsted, quality assessment frameworks, in health we've got QUIP, there's all sorts of different ways that we do that, but what we're not good at is measuring whether people's lives actually improve. And that's really what person-centered outcomes should be doing. If we really, really want to focus better on supporting people, we need to understand what they want to achieve much, much more. So one of the main, well, there's two difficulties. I see two things with developing outcomes, two problems. One of them is that people tend to embed the solution in the outcome. So what I often hear people say is, my outcome is to have 5 hours of speech and language therapy. My outcome is to have a car. My outcome is to have a personal assistant. None of those are outcomes, they're solutions. And we have a tendency, and often health practitioners are the worst at this, and I am a nurse by background, so I could say I've done this myself, that we jump to fixing a situation and we're not truly understanding what somebody might want to achieve before we think of the solution. The other difficulty I think that we have with outcomes is that we don't make them specific enough. So people say, I want to be more confident, but how can you measure that? So what are some of the things that you need to do? So what I want to share with you is some questions that you can ask that can help you think about whether this is a good outcome that you may have been developing with somebody. So first three questions would be, does what you're suggesting, so your 5 hours of speech and language therapy, does it keep something that is working for somebody? Does it change something that is not working for somebody, or does it move them towards a future that they want? So if it's not doing any one of those, maybe we would need to question why it's relevant. So that's the first set of questions that I would ask. Just want to take a minute to define the person-centered outcome and the difference between that and a solution. So a person-centered outcome is something that's personal to this person, not something that service wants to see. It's something that you have influence and control over. We can't set outcomes about things that we want other people to do. I have recently trained as a neuro-linguistic programming practitioner, an NLP practitioner, and there's a lot of work that we do around NLP on what we call the well-formed outcome, and I've used these criteria to inform my work around outcomes in planning. And one of the conditions of a good well-formed outcome is that it's initiated and maintained by the person. So that's really where that comes from. Another one part of the definition is it's as measurable and specific as it can be, including those subjective views. So understanding that when somebody says, I want to be more confident, we know what that looks like for that person. So we understand that confidence for them is maybe standing up and speaking in front of a room full of people, or actually stepping foot out of the house and doing my own shopping means I'm more confident. But we understand what it means to the person, not in broad terms that we may understand. And it may have obstacles in the way of achieving it. So that's a definition of a person-centered outcome. A solution is the resource you need to achieve your outcome. It can be an item or activity, it could cost, or it might be free. So that's just the difference between those. So if you're working on outcomes with somebody and they say, oh, I've got this outcome, and you think, no, that I think is a solution, then these are some questions that you can use to help you think about that. So firstly, if somebody has said, I want a car, and I've got a number of slides to show you with examples, ask them, what would that give you? Ask them, what would that do for you? Ask them, where, when, and with whom would you want that? And what would it make possible for you? And you can keep asking those questions. And as you ask them, what it will reveal is what the true outcome is for somebody. So they're a great way of testing. So let's just give you an example here. So somebody says they want a car, and this is a real example. There's definitely somebody in one of the pilot sites who wanted to use their personal health budget to purchase a car. So if you were to explore that, you would say, what would that give you? Well, it would give somebody transport. What would it do for you? It'd let you go and visit my friends once a week and do my shopping on a Friday. What would it make possible for you? Spontaneity, allow me to give other people a lift, allow me to feel equal to other people. If you then look at all of that, what your real outcome could be is to go and visit my friends, Liz and Anna, once a week and do my shopping on a Friday. I've been recently having quite a debate with a number of people on a group site around outcomes. And actually what one of the people I've been having a discussion with has said is that he sees outcomes as the achieved, something that you've achieved. So you could even phrase that outcome slightly differently and say, I am going and visiting my friends Liz and Anna once a week, and I am doing my shopping on a Friday. That's when you find out what the real outcome, and you phrase it in the tense that it's positive and it's something that's being achieved. So just to share another example, and I've mentioned speech and language therapy several times. So what would it give you? Time with a speech therapist. What would it do for you? Help me be more easily understood by my friends. What would it make possible for you? Friendship, social activities, feel confident around other people. So the real outcome, to be understood by my friends so I can play with them at the after school club every day. And maybe if we were rephrasing that into that I've achieved that, I am being understood by my friends as I play with them in the after school club every day. And then I've got one more example to share with you. A personal assistant, again, something that comes up quite a lot with personal health budgets, and one of the ways that we've seen people get a lot more flexibility. So what would a PA do for you? It'd be somebody to help me. What would it do for you? Help me wash, dress, go out, eat, move, make possible for you. A life. I could go to work, I could see my friends, I could feel equal to other people. So the outcome, and I've suggested two here because I think actually there'd be a lot of outcomes from having a PA as well, or the PA would be the solution to those outcomes. So to work 3 days a week and to have the right support when I'm at work, or to go out with my friends to the youth club on a Thursday evening. So that's just some examples about how I've been thinking about outcomes in a different way and trying to work with people around developing those outcomes. Once you've got your outcome, that's when you can look at the solution rather than jumping to the solution immediately. And a couple of questions that can really help with the solution is, what is stopping you? So what is it that's the obstacle that's in the way that means that you're not reaching your outcome at the moment? And what else could you do? And you can keep repeating these questions until you find a solution that works for you, really. I'm going to show you one more slide, and then I'm going to open up for questions, or pass you back to Kerry for questions, in fact. So I mentioned the outcome grid when I was talking about different sections. So I'm going to work from the left to the right here. This is my way of presenting in a support plan the outcomes, matching them against the area of eligible need that somebody has, and looking at the risks. And it just means that a decision maker can see it all pulled together. So it's quite a useful, almost summary. So on the left we have the area of eligible need. So if, for example, if we were working with somebody who has continuing healthcare funded, and to share a story, I worked with somebody called Heather who receives additional oxygen at 4 litres a minute. What wasn't working for her was that her oxygen concentrator that provided that oxygen wasn't portable, so she couldn't go out. So the area of eligible need would be breathing under a decision support tool. The outcome she wanted to achieve was that she was going out, when she was well, she was going out twice a week to meet her friends, and she was maintaining her oxygen saturation at above 96%, and that's what her health consultant says she needs to do. What's getting in the way of achieving it now was that her oxygen concentrator was not portable, so she couldn't take it out with her, and she was because of the level of oxygen she was on, she couldn't take portable cylinders. What's the risks if I don't achieve this? I think this is really important for decision makers to understand. If we don't do anything, these can be the consequences. So for Heather, there was 2 possible consequences. Either she was going to get very isolated and withdrawn and depressed, which could lead to further support needs, requirements, or she may risk going out without oxygen, and that could lead to chest infections and hypoxia, and actually really serious situations for Heather. Her ideas for achieving it is an portable oxygen concentrator. Then it was about looking at the risks for that. So for a portable oxygen concentrator, we could think of 2 risks. We thought, firstly, it might break down. A way of mitigating that risk is to have a service contract, and that service contract costs about £150 a year, and that would come out of the budget. And the other risk associated with that was the battery might run flat. We thought of 2 ways of mitigating that. Firstly, they have a spare battery, and secondly, the oxygen concentrator is always plugged in when she's at home. So there's like a protocol that her PAs follow that say the minute we get in the door, we plug it in, so it's permanently on charge, and they know it's therefore always charged. And then the cost of that was about £3,500 for that oxygen concentrator, and that's just putting that cost together. So that's really all the things I wanted to share today about personal health budgets and the planning that I've been doing within personal health budgets. So I'm going to pass you back to Kerry now, who has been listening to see if there's any questions, or looking to see if you have any questions that you want to ask me now. So Kerry, are you there?
Thank you, Jo. Hi again, everybody. We don't have any questions at the moment, so if there is anybody on the webinar today that would like to ask a question now to Jo, if you could just raise your hand for me so that I know that you're going to type a question into the box, just to make sure that we don't end the webinar when you've got a question to ask. Okay, so it doesn't appear that we've got any questions on today's webinar, Jo, so I'll pass back over to you.
Okay, so that's great. I hope that was really helpful information for all of you. I know sometimes it's hard to process everything when you've just been listening to somebody talking for nearly 50 minutes, actually. So if you have any questions at all that come up, I'm just going to move my slide again. Please feel free to email me at the email address you can now see on the screen, jo@helensandersonassociates.co.uk, or if you want to email Kerry, it's the same, it's Kerry@HelenSanderson-Associates, and she will pass that on to me. And you can see this recording will go up onto YouTube at some point, and please feel free to look at our Facebook pages, our website, and follow us on Twitter as well. So if you do have any questions subsequently that come to mind, please feel free to email those to me. And thank you very much for listening.